This conference will now be recorded.
Okay. So, Len, why don't we, since we're a small group and we said we would do this, why don't you take us through some of the ASCO highlights for prostate cancer?
Alrighty. Yeah, do you want guys to talk first? We can do it at the end. Make sure we give everybody a chance.
No, I think we've got a small enough group. Let's do it now, and then there may be questions that the guys have that come out of this.
Okay. So here's one I summarized: age-related efficacy and safety of apalutamide plus ongoing ADT in subgroups of patients with non-metastatic castrate-resistant prostate cancer. What they found in this post-hoc analysis of the Spartan trial is that there was no difference in efficacy of apalutamide for patients in 3 different age groups: less than 65, 65 to 75, and 75 and older. Now, that's not terribly exciting, but there was a comment from the author who summarized the trial results, and I'm going to read it directly. Apalutamide has been compared with enzalutamide, and no significant differences have been observed, although apalutamide has fewer reports of hypertension compared with enzalutamide. So I bolded that in the summary that I posted because if you remember last week, Peter was telling us about Associated Press wire stories about apalutamide being a wonder drug, and clearly it really doesn't have much to distinguish it from enzalutamide as far as we can tell so far. Now, there were 2 separate presentations on Zytiga, Zytiga alone. One was Zytiga
Can I just
alone.
interrupt you for 1 second?
Yeah, go ahead.
Gents, all of these little summaries have been posted to our blog. So Len's going to take them through us, but if you go to the blog page of the website and you scroll down, you'll find a whole host of these little summaries that Len has kindly put on there from ASCO 19. Most of them are categorized, a couple of them are not, so we'll fix that. So you could probably also search under either prostate cancer or recent news, and you would come up with them too. Sorry, Len,
Yeah, Rick, I just posted the link to the blog post in the chat box.
Thank you.
Okay, so there were results from the SPARE trial, S-P-A-R-E, where they were treating patients with Zytiga alone or Zytiga plus ADT. So they were sparing ADT in one arm of the trial, and what they found was that the primary endpoint of the study being radiographic progression-free survival at 1 year, there was no difference between the 2 arms. So Zytiga plus Lupron or Zytiga plus Degarelix or Firmagon, just no better than Zytiga alone. Then there was another trial that demonstrated, once again, Zytiga alone was just as effective as Zytiga plus first-line ADT drugs like Lupron and Firmagon. just as effective in suppressing testosterone. No difference. So if there are folks out there who want to save some money, or maybe hope that you'll have less fatigue, peel away that, well, talk to your doctor, of course, but talk to your doctor about maybe just using Zytiga alone without the first-line ADT drugs.
Well, I think I read that one. Didn't they say, though, that PSA and biochemical recurrence occurs faster in those who took the Zytiga alone?
Which study was that, Jake?
Oh, geez.
What was it?
I thought it was the one that you posted. I mean, I went to the ASCO site myself and I read some of them, and I assume that's the one you're talking about.
Well, but what I mean is, was it the study that just looked at testosterone levels, or the study that looked at efficacy?
Efficacy.
Okay. So what we're often told by people, as Adele told us when he was online with us a couple of weeks ago, is you don't want to be treating PSA. You want to be treating the cancer. And if all you're doing is looking at PSA, it might be meaningless, because the results of that study with Zytiga alone versus Zytiga plus ADT showed no significant difference in radiographic progression between the two arms.
Okay.
Now, if there were some differences in PSA levels, I'm not sure I recall that, but I take your word for it. Apparently, it didn't make a difference in the radiographic-free progression, which is really what matters. But I'll have to take another look at them and see if there was any significant difference in the PSA. Let's see. That was a highly technical presentation I summarized, which I'm not going to go over here because there's an awful lot of gene terminology, RB1 loss, P10 loss, TP53, other even less familiar gene acronyms. But you might want to take a look at that. It was titled Predictive Biomarkers in Prostate Cancer. And they took note of the fact that certain gene mutations will result in a poor prognostic sign for mCRPC patients. So, actually, I'll just read my first sentence here. I said, I'm afraid this is a highly technical blog post, but the take-home message should be that having your advanced prostate cancer genome sequenced for actionable targets, biomarkers, can do much to inform both you and your oncologist on which treatments are likely to benefit you most and which are likely to fail. So bottom line, if you haven't had it done already, get your genome sequenced if you have advanced prostate cancer. Another interesting presentation was the comparison of patient preference for in metastatic CRPC. More patients preferred cabazitaxel compared with docetaxel, 43% versus 27%, with 30% of patients having no preference. And for those who chose cabazitaxel over docetaxel, the reasons they gave were basically quality of life issues such as fatigue, hair loss, or pain. This I thought was interesting too. There was a presentation on IMRT radiation to the prostate alone, or the prostate plus pelvic lymph node or whole pelvic region. And the 3-year results of that study, looking at GI or GU toxicity, show that there was no significant difference in toxicity between radiating just the prostate or the prostate plus the whole pelvic region. And if you've got a high risk cancer, my takeaway from that is you might as well have the whole pelvic radiation because you don't know if there are some lymph nodes there that haven't lit up yet, and you're apparently not risking any further GI or GU toxicity. I think there might have been one other.
Did you summarize the Enzamet trial, the one that Sweeney was talking about, that Sweeney talked about?
I didn't, and I remember there was a reason why I didn't, but I can't recall the reason now. I think it was because they said it wasn't practice changing. I was trying to focus on only results that were practice changing. So I think that was that the one where they compared enzalutamide plus enzalutamide or enzalutamide plus metformin? Was that, or was it?
I think wasn't that enzalutamide versus enzalutamide and abiraterone together? Let me look.
That one, which I thought was old news, indicated that there was no benefit to using both drugs together.
Right.
Only added toxicity, but no efficacy.
Yeah, and I think that was the Enzamet trial, which also was released for ASCO, I think, but I'm not sure. Let me
just judging by the name, I'm thinking Enzamet was enzalutamide plus metformin, and I believe it was in non-diabetic patients, and there was no difference between enzalutamide or enzalutamide plus metformin. There have been indications that metformin is helpful in patients with metabolic syndrome or diabetes, but this result showed that it appeared to be no advantage if you don't have diabetes. No advantage to adding metformin.
No, this is actually not. The Enzamet was not with, it sounds like it should be with metformin, Len, but it was not.
Oh, okay. Well, what?
Okay, I'm just looking at it here. It was a double-blind trial. It was designed to investigate whether the combination of enzalutamide plus standard androgen suppression, which is LHRH, had better outcomes than a non-steroidal anti-androgen plus standard androgen suppression. So the non-steroidal anti-androgens were bicalutamide, nilutamide, or flutamide. So basically, it was looking at whether enzalutamide with an LHRH was superior to enzalutamide plus Casodex or nilutamide or flutamide. And I believe it found, as Len said, that it was definitely superior.
Right, and we knew that.
Right, exactly.
We knew enzalutamide was better than those first generation anti-androgens.
Yeah. That enzalutamide works a lot better than the old forms. And I think Len was probably right in not summarizing that. And I seem to remember when I read that, I thought, oh, that belongs in the no shit Sherlock folder.
Yep.
So, you wonder sometimes why the hell they do these studies after all these years when we've been using it. But I guess I raise it because it's been getting a lot of publicity. Now, there was another study Len and I both looked at that they talked about with, wasn't it with enzalutamide and pembrolizumab and Keytruda?
Yes. Oh, yeah, the one summarized by Dr. O.
Yes. Yeah, and they looked at enzalutamide with a bunch of different things and basically found out that, or they looked at pembrolizumab with a bunch of different things and found out that it wasn't much better than the different things. Is that a good way to put it, Len?
Yeah, right. Enzalutamide plus Pembro is not better than enzalutamide alone.
Yeah.
And I think it was Pembro plus docetaxel was not better than docetaxel alone.
Yeah.
So, I mean, it kind of
Yeah.
put the kibosh on pembrolizumab in combination.
Right.
Not to mention all the extra side effects.
Right.
Yeah.
So, I don't know that there was any sort of real startling news that came out this year. Would you say, Len, anything that was really
Yeah, nothing shocking, nothing
changing?
that's practice changing, except again, possibly the fact that you might not need ADT if you're using Zytiga. You can use Zytiga alone.
Did you see anything about ARV 101?
Yeah, ARV 110, I think it was. Yeah, we did.
Yes.
And
The
it was,
FDA is going to fast track.
yes, fast tracked by the FDA. And Rick and I were both surprised to hear that the FDA is fast tracking something that has never even been tested in humans yet. Usually they wait to see some positive results in early clinical phase trials.
Well, I think they did a phase 1, but it's only like 20 people.
They're doing a phase 1.
They're doing it, but
Okay.
they're just recruiting, but there's no results. Yeah.
Yeah, because the advantage of that is it attacks the ARV7 and degrades it, which
Yeah.
I presume would then make you make your cancer susceptible again to Abby or Enzo.
Not really. So we'll talk a little bit about it because it's really interesting. And I've been getting my own private tutorials from Len and Professor Bill. This particular study happens to be very much on point for Bill, because when they did Bill's analysis, they found a gene mutation that over-amplified his androgen receptors, meaning that his androgen receptors were super sensitive to picking up the testosterone. And the first thing that Len commented to me on this study, which was published this news was published yesterday in a couple of different places. Mike Scott picked it up, but I saw it in the original too, is that this drug, which is called, what's it called, Len? Promet? Pro something?
Oh, Protec.
Protec.
PROTAC. Yeah.
Yeah, has been fast tracked by the FDA before it even got to phase 1. And what I did is I checked where it was being tested. There are 4 sites across the country, and one of them is at Mass Gen. And so I told Bill, and he's speaking to his doc at Dana-Farber to see whether he would be eligible for the Mass Gen trial. It is a company-sponsored trial, but let me hand over to Len to explain to you why this is really innovative. This is a different way of looking at the controlling prostate cancer. Len, you want to explain to the guys?
Yeah, sure. So, as we know, enzalutamide blocks the androgen receptor from allowing testosterone to attach. That's its mechanism of action. Now, what happens, as Rick just mentioned, guys like Bill have a high copy number of androgen receptors. So instead of, let's just take a number, 5 androgen receptors on a prostate cancer cell, there could be 10 or 50 or 100 androgen receptors. And so now enzalutamide's job has become very difficult. It's got to compete with testosterone for multiple copies of this androgen receptor, and eventually loses the battle. Now, what this new drug does, instead of occupying the receptor and blocking it from testosterone, it just completely destroys the androgen receptor. Androgen receptor is a protein, and this drug has proteolytic activity, which means it lyses or it dissolves the peptide bonds of the protein in the androgen receptor, and it just completely it targets it for destruction by another organelle within the cell called the prostate cancer cell called the proteasome. Proteasome just gobbles it up and dissolves it. So the whole different mechanism of action. It doesn't matter how many androgen receptors there are, because this drug is not competing with testosterone to occupy a receptor. It's actually destroying the androgen receptor itself. So this was all done in cultured prostate cancer cell line called VCAP, VCAP, which has been cultured specifically as a cell line for testing drugs for patients who are castrate resistant. So this cell line has multiple androgen receptor copies, and it also has a mutation called TMPRSS2-ERG, which is a gene mutation, a gene fusion that results in proliferation of the cancer cell. So this new drug was effective in this VCAP cell line, which is very promising. It suggests that it should work in metastatic castrate-resistant prostate cancer patients. So I guess that's why FDA is fast-tracking it, even though it hasn't even gotten into humans yet.
So we'll keep you posted as to whether Bill decides to try and get into the trial. I mean, like Jake just said, they're only looking for, I think, 20 to 30 people overall, and there are 4 centers. One's in Las Vegas, one is in Boston, I think one was in Tennessee. I forget where the other one was. I've got the trial bookmarked, so I can pull the trial out.
The company itself is located in Connecticut.
Right. Oh, Yale. That's where the other one was. The other site is in Yale, in New Haven.
Oh, Rick?
So, yeah.
Yeah, I forgot to mention that the cap cell line that I just spoke of before, it also is positive for the ARV7 splice variant mutation. So once again, the new drug was effective in killing those cells, even if they are ARV7 positive.
Right. So that's really interesting. That has a lot of promise, but again, we've seen stuff with a lot of promise. I noticed. I was just reading. I was reading the Bristol Myers annual report that found its way onto my desk, and I noticed that they've abandoned Prosvac. So I remember when Prosvac came out 5 years ago, and I think it was nice. Icelandic or a Scandinavian country, and Dom, God rest his soul, bought some shares in it, and he was so excited. Do you remember then? Yeah, it's going up, and he kept looking at it. And as it turned out, Prosvac was a blowout, and although they're saying that it may be effective with other drugs, but on its own, it never did what it thought. So that's just sort of a warning for those of you who think, oh, this is the magic bullet. No, it may not be the magic bullet, but it clearly has some appeal. Otherwise, the FDA wouldn't have fast-tracked it. One other quickie for the benefit of Carl is that they reported on TOPARP B, which is the follow-up to TOPARP, and essentially found that the olaparib is very effective for men with germline BRCA mutation, which of course is something we know. It just essentially confirmed what they had found out, what the original study had shown. So I don't think there was anything really new in that TOPARP B. It was just a confirmation of TOPARP. So that's, we don't usually do this, but a smaller group we did today. That's a quick review. If anybody has any questions, again, look at the blog. Please check the blog. I'll probably say something about the ARV 110 when I send out our note next Monday, and so we'll create a blog post about it at that point. But if you've got any questions after that, we can try and help you. I'm just learning a heck of a lot because this is all complicated stuff for me. I'm trying to get my arms around it. But if anybody has any questions right now about any of the studies that we've talked or about anything else they heard of at ASCO, please air them. I'm opening it up for anybody.
This is Carl. And I have read that there seemed to be a good deal of discussion about PARP inhibitors overall. You discussed one of the items there. And one of the readings that I had seen was that, and they did say that the patients were pretty heavily dosed with other medications, but that the survival with the olaparib was positive. And but for me, I don't know how encouraging really is, because it says that it's an extra 8 months of survival. So I'm thinking, wow, okay. I mean, I've been on olaparib for about 3 months now, and I did have a follow-up meeting with Columbia Presbyterian just recently, and Dr. Stein even mentioned to me, he said, well, we're possibly going to institute a study for what's going to happen after PARP. And it didn't even occur to me that that's something I need to think about, maybe sooner than later. And of course, my results from the using the Zytiga with prednisone, after 6 months, it started failing. and I had hoped that I would get a year, 2 years, possibly out of that one. So here I'm now on a second medication. It's doing phenomenally well. I do have a follow-up meeting tomorrow with my oncologist. I'm not sure if he's going to do blood work to see where my PSA is at, but the last time it was done, a little over a month ago, the PSA was 0.02.
Okay, let me just interrupt you. I will come to everybody's individual situations as we go through. What I want to do is just hold this into a discussion about what was talked about at ASCO. And we'll definitely come back to you, Carl. We'll give you plenty of time to discuss what's going on and with that tomorrow. But if you have any specific questions about the olaparib or the study or anything that you read, that's what I'm trying to get raised now, as opposed to people's own particular situation.
Right, and that's why I did mention the fact that based upon what I read, that the survival is an additional amount
8
of
months.
months. So
Yeah.
and also I was curious how you guys got to go to the conference, whether it was available to patients or was strictly for doctors, or because of your organization that you were able to attend.
Well, let me take the easy one first. We didn't attend.
Oh,
So we could have attended. It's not that expensive as a patient advocate to attend, but the cost of getting there, the cost of hotel rooms is very pricey. And I actually applied for a scholarship and I didn't get it. We talked about it being there as an organization because one of our affiliate organizations was there last year, and we just decided it wasn't worth it. But it's really a madhouse. I mean, there's 35,000 people that attend this conference.
wow.
And there's a huge amount of information that is disseminated for many, many different cancers. Not just, this isn't a prostate cancer conference, this is a cancer conference. And so, for me, I would have gone more to network. Len probably would have liked to have gone to attended the sessions. But what I had asked Len to do was to keep his eye on what was coming out and to summarize those presentations that he thought were most appropriate.
I don't have any questions at the moment, but I would like to thank Len for going through them and eliminating some of that jargon. You boiled it down to understandable terms, and I appreciate that, and thank you for that.
Yeah,
Well,
thank you.
pleasure. Glad to help. And if that wasn't clear to anybody else, feel free to ask questions.
And as Rick says, the summaries are on the web page under the blog. So Len just kind of summarized his summary. You can read the full summary that Len came up with on the blog itself.
I do want to come back to this issue about the 8 months. I'm looking at one summary of the TOPARP trial, which I'll put right now in the window from MedPage Today. I don't see that 8-month figure. Oh, yes, I do. The median progression-free survival was 8 months. So that's progression-free survival, meaning how long you're on the drug before your disease progresses. I think the point that Carl made is an important one, in that these were men that had a confirmed BRCA1 or BRCA2 alteration, What we don't know, and I think there was a variety, is what previous treatment they had had. And because there were a number of previous treatments that were allowed within the TOPARP trial. And I think that's pretty important. I mean, what we've known is that the men that we've known that have used this drug have but they've gotten anywhere from about 6 months to about 2 years out of the drug. And I think that's the key thing, that when you go on these drugs, that you know they're not going to cure you. It's a question of how long they're going to manage. And what we don't know, which is exactly what what's his name? Stein, is it? At Columbia Presbyterian? I always forget his name.
Yes, Stein, yeah.
Yeah. What we don't know is what you do afterwards. This is the issue that's been puzzling Professor Bill for the last 2 years. And one of the things that we've said is, well, what about if you took a second-line PARP inhibitor, because the second-line PARP inhibitors are a lot stronger than the first line. So would you then respond? And there's a thought that, yes, you may well do, and that might be what Stein. So, when you next see Stein, I think the question that we'll want to know is, well, what are you thinking about in terms of what comes next after you've failed? I'm sure that Carl, you've talked to Professor Bill about what he thinks, and I know that he's very much in the camp that he feels, if he could get it, that a stronger PARP inhibitor, because both talazoparib and the Clovis one, rucaparib, rucaparib, are more powerful. The rucaparib is 7 times more potent, and the talazoparib is supposed to be 100 times more potent. Have you did you talk about that with Stein at all? What he thinks would follow?
Well, this is not something that's been on my radar, quite honestly. I had anticipated that it's going to be effective for me for some time before I have to think about it, but now it's on my mind.
Yeah, well, it may be effective for some time. It may be effective for some time. I mean, I've got a couple of skills, but we'll ask you when we come back to you on your own individual situation. But what I am really more intrigued about is follow-up treatment. What's the follow-up treatment to a man who, where Lynparza or olaparib no longer works? Just not sure. Just not sure. So I'm just looking here. I'm reading this report as we're talking, the one on from MedPage Today, and it says that overall 98 patients were randomized, 92 treated, all had progressed on ADT, 99% had done docetaxel, 90% had done Zytiga, and 38% had done cabazitaxel. What I don't really understand from this report is how that ties into the 30 men who had confirmed mutations in BRCA. So it's possible that some of these people that were on this trial were not necessarily BRCA positive people. They were just people that they were testing out olaparib on. So again, you can read the trial for yourself. So again, of those 30 men, I don't know what their background was. We'd have to go to the TOPUP trial or go to the posters to see these 30 men with confirmed mutations who had a median progression-free survival of 8 months, what in fact their previous treatment was. There was another study that came out of ASCO. I don't think Len has summarized it, which did indicate that cabazitaxel prior to abiraterone with men who had high volume disease was more effective than going straight to abiraterone. And I thought that was something that was worth catching attention. Does that ring a bell with you, Len?
No, I'm sorry I missed that one, Rick. That doesn't ring a bell at all.
Yeah.
Take another look.
Yeah.
For anyone who's interested, I posted the actual link to the ASCO abstracts specifically on GU prostate. So you can go down the list and select the ones you want. They're not nearly as easy to read as what Len gave us. Like I said, he did all the hard work, the slogging, but you know, there's a lot of studies. It'll probably take several months to go through them all, I would think.
How many are there on that list?
Huh?
How many are there on the list?
Oh, I don't even know. A bunch. Let me look again. Let me see if they count them.
Okay.
I don't see the post, Jake. Did you say you put it in the chat box?
Yes.
Yeah, it's in the chat box.
I think it's number TPS 5094. The one that's you just
yes.
the abstract.
I'd say there's at least 70 or 80, Rick.
Yeah,
well,
that sounds about right. Which, Carl, is the issue when you go. You know, it's kind of overload, which is why some of these people don't. Some people just don't want to go.
Right.
It's kind of easier just to sit at home and slug through and see what's important and what isn't important.
It's definitely geared more toward the professionals than the patients themselves.
Yes.
Oh, this is a very much a professionals conference, although they are open to patient advocates.
Yeah, this is not like PCRI, Carl, which is strictly for patients. ASCO, as the name suggests, is for clinical oncologists.
Yes.
Very much so. Very much so. And I'm finding this cabazitaxel thing. I'll put that in there too. But this was from the this was from the European Urology Conference that was in May, I think. But I'll put it in here since we're sort of there we go. Okay. All right. Anybody else have any questions on ASCO? Okay. Well, that's good.
Are you going to keep working on these, Len, for us? I know you haven't been able to go through them all.
Oh, Len. Oh.
No, I will. Yeah, I like this stuff. I'll take a look.
All right. Well, you know, any of these studies that you find that you would like to summarize and post, Len, thank you very much. And if anybody else has anything that they think that we should put on our blog, let us know and send it to us and we'll post it on your behalf. We may have we may reserve the right to edit. What do you think, Len?
We may need to. I don't know.
Okay. Okay. I'll have to talk with my editor-in-chief, Jake Hannum, and see and make sure it passes. All right. So let me just see if I've got everybody's name written down who's now joined us, and go down the list and see who would like to talk about their own situations today. And definitely, we know Carl has some stuff to talk about. So Jake, do you have anything? How you doing? How you doing with your appointment?
Still no word. I can talk about that for a moment if you want to.
Yeah. Let's see if how we can get some attention there. Len, anything for you?
Just a PSA update.
Okay, we'll take it. Dennis, anything for you?
Nothing for me, Rick. Thank you.
Les, anything that you'd like to talk about today?
I don't believe so. Thanks.
Okay. Ken Anderson, anything you'd like to talk about?
I can also PSA update.
Okay. Carl, I'm ticking you off. Paul Frieda, anything you'd like to talk about?
Yeah, I got a question about anti-angiogenesis.
Okay. Larry Fish, anything for you? Mr. Fish, are you there? Calling Mr. Fish.
He's muted.
Okay. He's muted. We'll wait and see when he unmutes. Peter, you have an update for us, I believe.
Yes, I'll do it.
Good man. Sylvester, anything for you?
No, thank you. I apologize for being late, and I might have to leave early. Thank you.
No apologies required. We are drop-in. It means you can come in and leave anytime you like. We just like to see your smiling face and know you're well.
I certainly feel welcome, and thanks again.
Okay, you're always welcome. Very welcome. All right. Did I cover everybody other than Larry Fish?
Did you ask Les?
Yes,
Shut her up.
I did.
Okay, he's also muted.
I know.
Ed Anderson, he's muted too.
Yes.
Okay.
I know. But they answered me. Okay.
They're being
All right.
polite and muting themselves. Good.
They are. Thank you very much. All right, let's start with you, Jake, since you got the microphone. And, tell us what the heck's going on there and why we can't get you in to get your scan.
Okay, well, I have called the radiology people several times. My oncologist has called them several times, and they keep saying that the company that makes it, Blue Earth, is waiting for insurance clearance. I don't know why it's taking so long, because I know Axamin is approved by Medicare. I think it may be because the 20% that Medicare won't cover, Blue Cross, my secondary, might be balking. But they keep saying that they have to, they're getting approval, trying to get approval, and that they will let me know when it comes in.
Your secondary is carried by Blue Cross.
Right, Federal Blue Cross.
There's no way that Blue Cross can be balking at this, because this is a Medicare-approved procedure.
Not necessarily the case. Not necessarily the case. For me, I had a PET Aximum scan 3 months ago. I have Horizon Blue Cross Blue Shield. They initially denied it while they approved the PET scan. I was just on the phone with the diagnostic center. They are now insisting that I give them payment, and they said that their experience with Blue Cross Blue Shield is that they have not had any patients who got approved for reimbursement for the maximum. So I may be on the hook for a $5,000 bill at this point. I just paid half of it this morning on my credit card.
Well,
Ouch.
are you on Medicare yet or not, Carl?
No, 64 and a half right now.
Right, but the Medicare, what I'm saying is this is a different situation to you because Axumin is Medicare approved, and Jake has a Part B
Right.
coverage, and so if it's Medicare approved, they can't be how can they be turning it down?
Yeah, that's definitely one of the items that was provided to Blue Cross Blue Shield, even though I'm not on Medicare, but they provide the documentation. Hey, Medicare has it approved, but it's still under review.
Have you called Axumin, Jake?
No, I have not. I've called the radiologist and I've called the oncologist.
Okay, so I am looking at their website because I remember this from before.
Yeah. Blue Earth, right?
Well, it is Blue Earth, but it's actually an Axumin.com website.
Okay.
I'm getting some feedback from somebody. I can hear it coming from, I don't know, I can hear it just my echo.
Does it sound like a fan?
What's that?
Does it sound like a fan? Because it might be mine. It might be me.
No. I'm actually getting feedback. I can hear myself.
Oh.
So I've just posted in there the in the window the Axumin website, and this is for reimbursement information. And what I would do is I'd call them myself. And there's a telephone number that I'm going to put in. It's on that link, but there's the actual telephone number. And I call them myself and find out what's going on.
Okay.
And Carl's situation, again, as I say, is a little different. But Carl, you might want to talk to Axumin yourself and see what the situation is in terms of coverage with the different insurance companies. They may be able to help you. They're usually pretty good and pretty nice there.
Yeah, this is great. Thanks.
And please let me know how you get on. Okay, Jay?
Yeah, it may be an issue with the company itself, Rick, because when I had my my original PET CT back in 2012, the FDG, Blue Cross, at that time I did not have Medicare, and Blue Cross did not cover any of it, and they sent me a bill and I never paid it, so it finally got written off. But so that might be part of the issue too. They have not said anything to me about that, but that might be the issue. My name might be flagged. I'm sorry.
Oh, your name might be flagged. I don't know, but I would definitely get hold of Axumin and ask them and tell them this is the insurance you've got, and you want to know.
Right.
But when you say the company, who's the company?
Community Radiology in Olney, Maryland, Olney.
Oh, so you think it might be them who's busting your chops rather than
Possibly.
Blue Earth?
Even though they're not saying that, they're saying they have to go to California for approval, whatever the hell that means. It sounds to me like they're kind of blowing me off, is what it sounds like to me. But that's the only answer I've gotten. They submitted all the paperwork, and now they're just waiting for approval.
Well, I mean, it does seem. Now, one other question on that, which is, where else could you get it done? Is there anywhere else you could get it done? What's your zip code?
20707.
20707. Okay. You have a choice of 4. Community radiology, affiliated PET systems, Chesapeake Medical Imaging, or Chesapeake Medical, or one of 2 Chesapeake Medical Imaging. They're all within 9.8 and 13.9 miles.
Okay. You found that from the Axeman site?
Yes.
Okay.
So, you
I'll
know,
check them out.
go to instead of going to Olney, go to Silver Spring.
The trouble is, Rick, is I'm you know, my oncologist sent all my forms and paperwork and everything to Olney. They're going to really have a hard time sending them again to a separate radiologist, and I'm going to have a hard time asking them to do that. So I know the poor lady, the receptionist, she must have spent probably 3 hours copying my document.
But, you know, you need scanning, and you're not getting scanning.
I know. Well, it's only been 2 weeks. You know, I'm not in a real rush. I'll do like you said. I definitely will call Axeman myself and ask them. But I have a separate question that probably Len or you can answer. I looked up the half-life of Axeman, and it's like 109 minutes, 110 minutes rounded off. And the cyclotron is in Philadelphia. So will it, and we're like 2.5 hours from Philadelphia. So I don't know. I mean, I know half-life means it loses half its life or half of its potency in that time. But I don't know.
Jake, I'd ask the folks at Axeman what they think about that.
Well, only is one. There's only certain ones who are approved to do the Axeman, and Rick mentioned 4. Only is one of them. So I'm sure they know about the distance. But I looked it up. I looked up C11 is like a 20-minute half-life, and Axeman is 109.7 minutes.
Yeah, but again, don't believe everything you read on the internet. I mean, there may be ways in which they can transport it at certain temperatures, which change I just don't know.
Right.
And I think
that's why I was asking.
I have no idea. I have no idea. I just assume that if they're a center, they have the facilities on hand to mix up whatever they need to mix up right there, that they don't have centralized cyclotrons where they send out the formula every time.
Right. I talked to the technician, and then when on one of my calls, and she said, "Oh yeah, it's in Philadelphia." So can I ask her, do you have a cyclotron on site? And she said, "No, it's in Philadelphia."
Okay. Well, why don't you when you call, you can ask them, and if they don't have the answer, tell them that you'd like them to get back to you with the answer, or you're gonna go through the Axeman website. I mean, I'm looking at a page here where they have a timeline. And so, that may help you a little bit. I don't know, but you'll need to, I don't have any information. I don't know that Len does. But I think that you're the man. And when you're all done, you'll be able to write a blog post and put it on our blog, so other men can benefit.
Okay.
Okay.
Thank you.
Thank you. Len, give us your update, man.
Yes, not good news for me. I had a PSA check 6 weeks ago, was 1.28, and 6 weeks later, just as of last week, I had a redo, and it was 1.8. So that's about 30% increase in 6 weeks. Meanwhile, I am still waiting patiently, although maybe less patiently, to get into this NIH trial, which I've been waiting to get into since January. I can't believe I'm still not in this thing. I can't recall what I already told you guys. I was scheduled to go down there June 2nd, and the day before I was scheduled to go down, they had a heavy rain and they had a flood in the basement where the lab is, where they generate the radio tracer. And so then they had several weeks where they have to clean it up and get recertified. You know, it's a complicated procedure, bureaucratic and all that. So anyway, bottom line is now they've tentatively slotted me for it's July 18. Meanwhile, I've just, oh yeah, so I called Yale because they were also doing the trial and they were just waiting for my PSA to hit 2.0. And while I'm waiting and waiting for my PSA to hit that threshold, I called them up. I said, hey, I'm almost there. You want to start getting the process going? And the MD over there said, oh, sorry, we just closed the trial. We are fully recruited.
Oh, man.
So now I learned that MSK, it has its own trial, which they're also recruiting. So I'm going to contact them tomorrow, see if I can beat the NIH July 18 slotting. That's it for me.
Anybody have any questions for Len?
I don't know if I mentioned this is the PYL trial. It's supposed to be the most sensitive radio tracer available.
Len, what's your threshold number with Dr. O?
Yeah, that's a good question. He didn't really say we're going to have to do something once you hit a certain number. But hopefully he read my result. I didn't actually see him. I only had the blood test done last week. So I suspect he's not panicking about the 1.8. Because the most important thing is that we find out where the lesions are.
Len, have you had a C11?
No, but Jake, even Axumin is supposed to be more sensitive than C11 choline or C11 acetate. So I did have Axumin, and that was indeterminate.
Well, okay. I might have the C11 mixed up, but there was a head-to-head basically of Axumin versus something else, and I thought it was choline, but it might have been the PYL. And they definitely said that the Axumin is okay for higher PSAs, but definitely not for less than 2. Less than 2, Axumin got blown out of the water by the competitor. If I find it, I'll send that to you. It might have been PYL. Are you there, Len? We lost Len.
I think we just lost Len. He'll be back in 1 second. Yeah, well, Len, your voice is still showing. Are you there? Are you with us? I suspect not. I do know what you were talking about. It's pretty recent, and there was a study.
Right.
And the 18F PYL definitely shows as the best, and then the gallium, and I think it was Axumin versus the gallium 68 is what you're thinking about.
That's the one, gallium 68, correct.
Guys, I got dropped and I just came back.
It's okay. We were just talking about you. Don't worry about it.
Hey, I have a question to add. It's Larry.
Yes.
You
We
know-
know it's Larry. We have a question for you, Larry, before you ask your question.
You did? Oh no, we have our graduation rehearsal, so I'm trying to listen while we have all rehearsal going on.
Because we wanted to know if you wanted any time today.
Oh no, I'm okay. I just wanted, but the question I had is, so what is the recommended PSA when you should really? I mean, I had this conversation with Dr. Audio last time. It's like, so I'm now at 0.22, but it's not about my personal time. It's the general question of, so when do you push for getting a higher level scan? Whichever one maybe is Axeman, maybe right now Sloan doesn't do, Axeman was not available for them right now there, but they have I guess it's an acetate. But whatever it is, it's like, we decided, well, we don't want to do it when nothing is probably going to show. So when is the time to really push your oncologist to do a scan? Is it when it's like near 2.0 or when someone is most likely to show? That's the question. Anybody have any view on that?
Well, Larry, this is Jake. I don't know if you heard what we were just talking about, but Axeman is the only one that's FDA approved. Other than, well, it is the only one for prostate, the only one that's FDA approved. Gallium-68 is much more sensitive, as Rick, and that's what I was talking about, Len. I don't know if you caught that, but the one I was talking about in the study was Axeman versus gallium. Gallium is much more effective. They didn't compare it for higher PSAs, but anything less than 2, they kind of just said, don't even bother with Axeman. I don't know if that helps you answers your question, Larry. But if insurance is not an issue, then you could try to get the Gallium-68. Otherwise, you need to wait till your PSA goes above 2 for the Axeman to be of any kind of value.
That's what I was thinking. Is it? Well, I'm probably a little ways away from that. Not to do it ahead of time, even if you can. Right. So wait 2 or wait 4. I mean, what is it ideal?
Well, I think that the PSA, the gallium-68 PSA, we know the sweet spot for that is once you get north of about 0.65, and probably the real sweet spot somewhere north of 0.8 to 1. The 18-FPYL is probably a little lower. I'll let Len talk to you about what the sweet spot is there. And the Axeman, you've got to be north of 1, and they're saying, well, you've got to be north of 2, but we know people that are under 2 that have had good results. The other thing I just wanted to mention to you, Larry Fish, is that Len just mentioned before that there may be an 18-FPYL trial starting at Memorial Sloan Kettering. I think you might have missed that.
Yeah, I heard the word, but there was a whole song. I can walk back to the auditorium and you could listen. So I missed it. Yeah,
Okay.
I'm planning to actually go back and listen to the first hour of this on tape.
Okay.
Thanks a lot.
Len, this is Peter, Len. If it was me, I'd wonder if it'd be worth doing a phone consultation with the Scan King, Dr. Fabio Almeida. Just because he's probably up on where all the scans are and who's got them on trial, and whether he might even be able to push you into something that you're not aware of and get you to the head of the line. I don't know. He's a very personable guy, and he seems to. I mean, that's his world. That's his life. And if it's just a thought, it would be something I would consider.
Yeah, I did meet him at the PCRI conference, and he is a really nice guy. Of course, he's going to be biased. He's going to say, "Oh, you're 1.8. I can scan you with my C11 acetate," and he can. But I know that it's not as effective as as even Aximan, and I already had Aximan, and that wasn't sensitive enough. So I'm going to hang in there.
I think he's doing trials of other things though too. I mean, he's pretty hep on this stuff. He's not just pushing his own stuff.
Yeah.
Well, he was trialing a different PSMA agent with gallium-68, but I don't know if that trial's still open. And I could link Len to that, but I think at this point, given that his outside date is July with the NIH, Len's probably better off just moving along there. But by the time he gets himself sorted out with Almeida and everything else, it's going to be July. So, and maybe they'll put you in earlier, Len, than July. Maybe they'll have a cancellation or something, because you deserve it.
Yeah. Well, my first agenda item is to call Sloan Kettering tomorrow. They do have a PYL trial they're recruiting, so I'll see how quickly they can get me in.
Yeah.
Now, if I can take a shot at Larry's question, when do you push your oncologist for a scan? I would say, first and foremost, if you're symptomatic. Like I believe at some point, Larry, you had a bone met. So certainly, if you're symptomatic, get a scan done. But lacking that, as I think Rick and maybe others have said when I was knocked off, unless you can get a gallium-68 scan or the PYL scan, you don't bother doing anything until your PSA is probably 1.0 or higher.
Well, I've got a feeling Larry may be on and off the call, but I think he'll hear that when he listens to the recording, Len. And I think it's probably based on your own experience. I think that's probably pretty solid advice. If I can find the clinical trial for the PSMA, and I may be able to for the R1, I will put it in the box. Found it. Okay. All right. Here's the reference to Almeida's trials. I don't know if they may be out of date now, but I just put them in the box for you. You can go from there.
All right. Thanks, Rick.
All right. Peter, since you started talking to us, give us an update on your situation. I got a little taster yesterday when I was just on the low intermediate call at the beginning, but tell us what's going on in your world.
Yeah, as most of you know, I've been lucky enough to be in a an hormone sensitive state. So I've been doing intermittent like Len for the past 5 years since I was diagnosed. So this is my third time off of ADT, actually off of Zytiga as well. So I've started going back to 5 years, and it's been taking about 4 months for things to wear off. So my testosterone has gone up. It jumped up to 177 last Monday, and my PSA is bumped up a little bit, probably due to that. But it's kind of not significant. It's only like 5/100ths. Went from 0.02 to 0.07. My plan is actually I'm going to go over to LA and meet with Dr. Turner next month. And I'll do a blood test here before and just keep monitoring things. And if I got to come up with a plan for what I have to do. If I have to go back on anything in the fall, I'll do that. You know, I'm willing to just with it this way. It feels good to finally have some testosterone back. You know, being able to make a bicep muscle and not feel you can't stay at the gym more than 20 minutes. And you know, and I went paddling this morning and I felt great afterwards. So I didn't feel like collapsing. So I'm willing to hang in there as long as I can before I take a deep dive.
Chasing your girlfriend around the kitchen yet?
She's still in Minneapolis. She's not back yet.
Oh, she's in Minneapolis. Okay.
Hey, Peter, how is your hemoglobin and hematocrit recovering? Remember
It's still about the same. It's hovers around 10 on hemoglobin. It's been that way since the beginning, from 5 years ago. My white blood count has been up. That's been good, but the others are kind of on the low side. But it's
okay.
It's funny you ask him, Len, because that was the first question out of my mouth to Peter when he said that yesterday as well. How's he doing with his anemia?
Yeah, I think maybe it really dropped when I broke my leg, when I broke my femur. That might have somehow that might have triggered a big drop, the surgery or something like that. I don't know. But anyway, it's back where it's always been.
Peter, I have a question. You've been on and off the Lupron a couple of times. How high did your PSA get before you jumped back on your Lupron?
Not very high, because I don't have a prostate anymore, and I've had radiation and so forth. The scan, one of the scans that Len was talking about, I did that a year ago, a little bit more than a year ago, the PSMA, and I let my PSA get up to just below.
I didn't hear that.
0.8. I let it get up to last year, but it was doubling every 6 weeks. It was low PSA, but it was doubling every 6 weeks for about a cycle of 4 or 5 months. So that's when I went to proton beam radiation. And before that, it went up to 2 point something, and then I had IMRT radiation. Anyway, it's never gone up very high, but it has moved. It's been climbing steadily, and that's what I watch. How close together the rungs are on the ladder.
And right now, what's your PSA?
Oh, it's very low. It's 0.0.
Okay.
7.
All right. Thank you.
Okay. Any other questions for Peter about his intermittent hormone therapy?
Good luck. Keep it up.
Peter, I don't know when you came on the call. Before I was summarizing the ASCO abstracts and talking about a Zytiga study that showed it was just as effective alone compared to plus ADT. So if you ever do need to go back on, do you think you might consider monotherapy with Zytiga, or you'll go the traditional route?
Yeah, that's why I want to go and have a sit down with Dr. Turner. I heard that the other day as well. So, yeah, it's definitely a possibility. I just want to look at some of these things coming down the road.
Well, you may not be aware, Peter, but Len has very kindly summarized these on the blog. So you'll be able to find the summary of that on the blog.
I will look at it for sure. Yep. Thank you very much for doing that.
Peter, what's your Gleason?
I'm a 9.
9. Okay.
And it spread to the seminal vesicles. So it's in my system. I've got systemic stuff, so it's going to show up someplace again. It's just a question of where and when. I just want to catch it in the early stages when it does.
And when did you have your prostatectomy?
2015.
15. Okay. Yeah, I did mine in 14.
Okay. So we're going to go Ken Anderson, Carl Foreman, Paul Frieda. Ken Anderson, give us that update.
Well, I can tell you my doubling time is about 3.5 months.
Okay.
My most recent PSA was 1.17. And I'm still, at the moment, just doing Lupron. I did an MRI last week, and I did a biopsy this week. I'm going to wait, because I'm going to go on this hike here at the end of the week, which is rather an intense 2-week-long hike up in the Pacific Northwest. And when I get back to Arizona, you know, I'll have the results from the biopsy at that time to see whether or not there's any activity in the gland and to see whether or not there's any mutations, because I'm having it sent out to Foundation 1 to be sequenced again. That's kind of it in a nutshell.
Okay. So, I'm getting some. I think we're getting a little feedback from Ken, but that's okay. Ken, when what was I just? What is it that they are Foundation Medicine? Is it an old sample or a recent sample?
No, I just had a biopsy, so they're doing
Great.
what they just took.
Okay.
You know, Paul, I've been chatting with Paul pretty regularly the last couple of days, well, last week, and about the information that was given to me 2 weeks ago from Alan, and because quite honestly, I'm not in it for the fun, so if it's not going to actually extend life, I'm not sure whether or not I want to do high-dose brachytherapy. But he thinks if there's any activity in the gland itself, even if it's diffused, that it might not be a bad idea to go ahead and radiate it. So that's kind of the plan at the moment. I did have an MRI last week, and nothing showed up. So
so Quam thinks that it might be good to do the high dose brachy.
I said if there's activity in the gland after the biopsy that he couldn't see any harm in doing it. He doesn't know whether or not it'd lower my PSA, but it might. He doesn't know if, again, as Len stated, he doesn't know if PSA alone is the determining factor, but it's one thing they use to grade, you know, activity or non-activity. So he's okay with me Provenge too. So right after, I'm going to start Provenge as soon as I get back.
So let me just understand what that did they take a sample from your prostate or did they take a sample from the bone?
They did take a sample from the prostate, which they're sending to Foundation 1.
So the first question, and you haven't heard the results of this, so you don't know if there's activity. Is
No,
that what you're saying?
It just happened today.
Okay. So here's an issue, and Len, maybe you can help me with this one. But isn't there some difference between the metastatic samples and the primary sample?
Well, I think it's still somewhat controversial, but the metastatic lesion would certainly reveal the I forget the term they use now, the driving mutation,
Right.
the mutation that's driving the progression of the cancer. Now, whether that same mutation can be found in the primary tumor in the prostate, it's a little muddled. I believe some think that it is there, and others think not necessarily.
Right.
But for sure, the metastatic lesion biopsy will reveal the driving mutation.
Right. That's what was on my mind, Ken. So, you know, you might want to just check with Paul on his view. I'm sorry?
Yeah, he didn't bring it up when I was chatting with him, only because he knew that I was going to have the biopsy to the prostate to see whether or not there was activity there. And he said, since you're having the biopsy, then send it off to Foundation One and have it sequenced again.
It might have just slipped his mind. I mean, just send him a note and just say, is the prostate primary biopsy as reliable as a metastatic biopsy to identify the driving mutations?
Yep, it makes sense.
Okay, and I think we've got some previous discussion on that. It's come up before. I can't remember if it's Professor Bill who's talked about it, but we've definitely discussed that on here before. What we do know is that the metastatic lesions are pretty much the same across the board. So wherever you find a metastatic prostate lesion, it's going to look like any other metastatic prostate lesion in your body. But the discussion is whether the metastatic lesion matches the primary lesion, or something happens between the time it leaves the prostate and occupies a metastatic location.
Yeah, I think the problem was during my visit to MT Anderson in December, the PET scan didn't actually show any activities in bone at the moment.
Okay.
So I don't know if I could go in and biopsy a bone where there was a bone met if there wasn't, you know, activity that was evident on the PET scan. I don't know.
Well, I think then you have to decide if we're right in thinking that, and I recall conversations with Dr. Steve, God rest his soul, about this. We talked about it with Dr. Steve, so we're going back a year or two. But then you have to decide whether it's worth doing it from a prostate biopsy.
Right.
Okay.
Yep. I'll ask Paul and I'll let you know what he said.
Yeah, please do let us know what he says. Anybody else got questions want to discuss with Peter, with Ken?
I do. Ken, I thought your primary therapy was IMRT. Is that right?
Yeah, it was IMRT in November of 2017.
So what I think we discussed this before. What I don't understand is how he could be talking about brachytherapy. So in other words, re-radiating an area that's already been radiated. My understanding has always been that they don't do that.
They do not do it from, this is a needle-guided brachytherapy where they actually inject the gland with radiation. I mean, it's a different process, and yeah, they do both.
Oh, okay.
It's high-dose brachytherapy directly to the gland if there's any activity that is represented within the biopsy through pathology. I didn't show anything, but the comment was that if it's diffused activity, it might not show on an MRI. It did show in the scan. So, I mean, if there's nothing in the pathology from the biopsy, I am, of course, going to do brachytherapy. There's nothing. So, but if it shows up, I'm still considering it. But I'm going to talk to Paul one more time about both Foundation One information for recommendation as well as what to do. this.
You're breaking up quite a bit, Ken.
I know, I'm off my tablet. I'm pretty much at the moment, I guess. Anything else, Lynn?
Well, unfortunately, I didn't understand what you were saying there. You're breaking up so much at my end, but
Oh, okay. Did you get the fact that it's high-dose brachytherapy to the gland?
yeah, high dose meaning they insert a rod temporarily and then pull it out fairly shortly. Is that right?
No. It's actually, there's like 16 needles. It's a computer-guided procedure where they actually insert 16 needles and inject radioactive material straight into the gland, and apparently it gets like 100 times hotter than IMRT, with the exception of the area right around the urethra.
Okay, I guess it's a new technique.
That's what I believe as well.
Okay.
Well, new meaning 2 years ago. They started doing it here at Arizona Oncology, and Paul was familiar with it. So he said it sounded like a reasonable approach if there's activity.
Okay.
Len, I'm also not too clear. I think it may be something very similar to the rods. It might just be a slightly different instrument that's used, or a slightly finer instrument that's used, so that they're inserting a rod right into an area where they see they see activity. And you know, remember, of course, that in Ken's case, he had chemotherapy, and then he followed that up later on with his IMRT, which I think, Ken, correct me if I'm wrong, but the IMRT was to the gland and to the pelvic girdle, correct?
Correct, 82 gray or 84 gray, something like that.
Yeah. So, I mean, again, it's hard for me to understand when they radiated the gland, how come there's anything left in the gland? It's kind of unusual, but that's how it was. So,
well, again, we're not 100% sure there is. I just said Paul's comment from the PET scan in December that it looked like, the pathologist said it looked like there was activity, but quite honestly, that wasn't confirmed on the MRI, and it may not be confirmed on the biopsy.
Well, the first thing you've got to do is get your biopsy results.
Right.
And if the biopsy results are negative, then you don't have anything to send to Foundation Medicine anyway.
Correct.
So let's go step by step and find out what the results of the biopsy. When will you get that? Presumably after you get back from
yeah,
from
the
your
hike.
hike.
I'll come back on the 9th, so we'll have the information for that following week.
Okay. Well, you'll keep us posted, and we hope you have a wonderful time with your sister on the hike, and you don't finish up having to carry her out.
Oh, no, that'll be fine. She's been hiking, so as long as it doesn't rain on us every day.
Okay. All right. Well, what was it by you? 108 today?
I think it was 109.
Okay. Hot. Indeed hot. Okay.
You're going to be hiking in that weather?
No, I'm going to the Pacific Northwest to the Olympic National Park for a through hike. It's a 120-mile hike. So, backpacking and camping.
120-mile hike?
Yeah, it's actually 30 miles on the coast and then 120 miles through the park.
And you're doing it on, huh? You're doing it
I'm
with
doing it on.
Go ahead, Peter.
You're doing it with Lupron? That's amazing.
Oh yeah, I'm doing it with Lupron. That's why I'm contemplating, dropping Lupron if I can and just doing either enzalutamide or Zytiga. I'm not going to do Zytiga because apparently Provenge and a steroid don't mix. Paul's comment was there's something with the steroid that blocks immunotherapy or dampens immunotherapy. Does that ring true to you, Len? Well, it probably is.
Yeah, I mean, steroids are immunosuppressive, but the prednisone that you take with Zytiga is very low dose, and it's only designed to replace the cortisol that you're losing from the Zytiga.
Yeah, his comment to me was if there was a choice, since I want to do Provenge and I do have a choice, I wouldn't take Zytiga with prednisone. He said he would take enzalutamide since I am going to be doing Provenge. So that's kind of the route I'm going, I guess.
Okay. Well, have a wonderful time, and I guess we won't be hearing from you for a couple of weeks, so we'll think about you. Unless you feel like you have a signal and you feel like calling in and giving us a hike and weather report.
Well, we'll see.
Okay.
Thanks again.
Have fun. When are you leaving?
Friday.
Okay. Have a great time.
Thanks.
Good luck, Ken.
Okay, Carl. Now tell us about where you're at, and let's develop a couple of questions for you for your doc.
Okay. Oh, I got my printer going. It's a little noisy. Wait. In addition to what we already talked about with the PARP inhibitors and my scheduled meeting with my oncologist tomorrow, and forgive me with my brain fog that I've been having, but I don't recall if I've spoken to the group before. My latest issue has been a partial blood clot in my left thigh. I've since been put on Eliquis, and I've been told that's not unusual with all the treatments I've been going through. Still have, and the pain in the thigh is from occurs only at night. It wakes me up in the middle of the night. I don't have pain when I'm walking or anything like that, but I've been told that it will probably take about 2 months to get resolved, and I will need an updated Doppler within 90 days to just double check that the clot has dissolved, although it's not the Eliquis specifically that will dissolve the clot. As you may know, the Eliquis is a blood thinner. And in addition, I had blood work in conjunction with all of this, and I am being shown as being anemic. My hemoglobin is low at 11.7. My hematocrit is also just below the reference at 34.4. My red blood cell count is low at 3.84. It's just below the low of the range, each of those. And also kind of interesting is, so my alkaline phosphatase, which at one point was very high right before I was taken to Zytiga, which was an indication of bone disease, is now at the low end, just below the low end at 36, where it was 180 something when I first started Zytiga. So I guess that's probably a good thing that that's in that range. And also my pH from my my urine is high at 8.5.
So let me just, before you go on, let me just make one quick comment there. I mean, we know that the PARP inhibitor does have an impact on your blood counts. It's a well-known, acknowledged side effect of the PARP inhibitors. And it's also the result of having been on hormone therapy for about a year now. And as you heard Peter say, his hemoglobin is down around 10 and has been for an awful long time. So I don't want you to think that this is anything too out of the ordinary. I mean, it's kind of expected. Obviously, the blood clot is not, and you've got to do whatever you have to do. But again, what we've always said, to the extent possible, is that exercise, and especially aerobic exercise, is very, very helpful in increasing your red blood cells and your hemoglobin to the extent you can do it.
Yeah, and well, one of the things that for now I'm kind of on a hiatus from my cancer wellness program, which I've been going to for twice a week with a personal trainer and part of a small group. And just out of an abundance of caution, and again, I will address it again with the oncologist tomorrow. I did kind of I spoke to Dr. Stein, and he thought, well, keep up with the exercise, but I just want to make sure I'll address that tomorrow at my meeting.
Well, you know, you're hearing it from Stein, and check it again. But I mean, I know that there's always a concern about they don't want those clots to move around your body, but you are on the Eliquis, and it is going to be, and it would be helpful from the anemia standpoint, but there may be other downsides. So again, we don't give medical advice, but it's best to check it out, but just bear that in mind.
Yes.
So that's one big question for the doctor. Forget his name. Is it Ganison? Is it, or Soraya?
Soraya. Yeah. Yes,
Okay.
Ganesan is the precision medicine doctor who I don't normally see. I just saw him once, but Soraya is my oncologist.
Okay, Soraya. You know, Soraya and Stein, really good people to say, look, what are your thoughts once we move along? And,
yes.
and I don't want you to hone in too hard on that 8-month number of progression-free survival without knowing what the previous treatment and what the status of those people were who they measured 8 months on. We need to understand that, and then we need to check how similar they were to you. They may not have started the olaparib anywhere near as early as you did.
Right, and I've also had Provenge previously, so I hope that's a beneficial addition to the mix.
Right. So I think that I'm suggesting that it might be a good idea for you to pull up that Topart B abstract. It might even be referenced in that MedPage article that I posted up there before.
Yes, I did.
Look at it yourself. And, you know, then, and tell us, because you've got to make sure you're comparing apples to apples. Always a problem when these studies get reported.
Right.
So, like I say, we don't know, and we hope that you're going to continue. How's what's going on with your PSA?
Well, the last one was done, I think, about 6 weeks, 2 months ago, and the PSA had dropped after having been on olaparib for a little over 2 months. Now it's about 3.5 months, but at that mark, it dropped really great to 0.02. And I'm not quite sure if they're going to recheck it tomorrow, but I'm going to have my Xgeva shot tomorrow as well.
Yeah, I mean, I find it unusual, and I'd like the other guys to comment, because I have that late April. I just find it unusual that they're not measuring your PSA more often. Anybody else have any thoughts on that for somebody in Carl's situation?
Carl, what are they doing it once every 3 months?
Thereabouts, yes. And Dr. Soraya had said to me very early on, and has said it a couple of times since, that he doesn't want me, or just in general, to focus on the PSA number. No, you know, that's like, okay, yeah, but I still want to focus on that number.
If you get PSA anxiety, maybe it's a good idea just to do it once every 3 months.
Right, and I think that's his thought process.
I I think that's one reason. The other, how do we know how well the olaparib is working? What are we measuring to see? What you started that olaparib when?
It's about 3.5 months now.
Okay. So how do we know if the olaparib is working? I mean, what are we doing to check if it's having an impact? We know one thing it's doing, which is giving you some grief with your anemia.
Yeah.
But we need, I mean, anyone else think that checking, at least as rough as it is, the PSA might not be a bad idea when you start a new drug to see if it's having.
I guess, but if his PSA is only 0.02, I'm not sure there's any urgency to have it done more frequently.
Okay.
I guess
Let's
it's
just
whatever
say
Carl.
then, Len, let's just say that after 2 months, say you did it every 2 months, and let's just say the PSA showed it was 0.08, God forbid. We don't want it to be, but say it said 0.08. Don't you think that might have an impact on treatment decisions or how you're looking or what you might be looking for with the PARP inhibitor?
Sure. Yeah.
Going from 0.02 to 0.08?
Yeah.
Well, it's just my personal opinion. I don't think that's cause for alarm.
Okay.
You know, I can only say, that, MD Anderson's real adamant every 30 days. My doctor here locally was going to do 60, and he threw a fit. He said it was too far apart. So,
yeah.
I mean, earlier notice in regards to progression is key, I think, in deciding which path you take. I disagree a little bit with that.
Yeah.
I've been doing it every month for years.
Peter,
I've been doing it every month for at least 3 or 4 years.
Right.
Wow.
Anybody else?
Well, I'll definitely talk to Dr. Fry tomorrow about that and getting it done.
Look, if you have PSA anxiety, it is an issue. If you don't have PSA anxiety, I don't know what the downside is. I like Len have said many, many times and agree with him, a small change doesn't mean a lot, especially when you're looking, there's so much variance. But what concerns me is where you have this situation with with new drugs and new treatments. We're trying to see if you're responsive to the Lynparza, to the olaparib. And so, as Ken says, the earlier you get a feel for that, it may not mean you would stop it, but it might mean you would do some other things, or you might want to do an additional scan or something like that.
Yes.
And that's I think what we're pushing, not to scare you, but this is a different situation, I think, to people that might have more stable disease, and your disease, unfortunately, hasn't been that stable.
Right.
Carl, you know what I would ask your oncologist, at what point would my PSA rise to, at which you would decide there needs to be some kind of intervention?
Yes.
Like another drug. And then if he says, I wouldn't do anything until you're at least 0.5, whatever, then, maybe you don't need to have it done too often.
Right. I can tell you that my specific experience with the Zytiga was that it had lowered me down to 0.12 right around the time of my robotic surgery. And then right after the surgery, it just kept creeping up, and it crept up to 0.55. And that's when the oncologist said, well, it really looks like the Zytiga is failing and we need to change therapies. So.
Yeah.
Good question. Thanks.
I think the bottom line, Carl, is different styles for different doctors, different institutions, as you hear. And all we're doing is raising the issues and putting them on your radar so that you can talk it out with your doc.
Yes, it's greatly appreciated.
Okay.
Thank you.
All right. Anybody else want to? We're going to go and talk about angiogenesis with Paul before we hang up. But does anybody else want to say anything to Carl? Okay, Mr. Frieda, throw us your. Yes.
It's a quick one. I'm just wondering if anybody has heard of anybody doing anti-angiogenesis treatment for prostate cancer. I can't find anything on the net. I do know the lady whose home I stayed at when I had my prostatectomy. She's on Avastin, and it's holding off her ovarian cancer. I was wondering if anybody knows anything about this therapy for regard to prostate cancer. Probably not, but just I'm throwing it out there. It looks like a quick one.
Yeah.
Well, no, it's not a quick one at all. But Len, go ahead.
Yeah, I know it's approved for anti-angiogenesis compounds are approved for advanced prostate cancer. So there must be some efficacy there. But I don't know any of the details about when it's appropriate to use such an agent.
Well, it probably when someone does not, for one reason or other, does not remove the prostate, even though they know they have cancer there, and so it's that might, because it's supposed to block the the creation of blood capillaries to feed the tumor. And
Right.
So, if it's prostatectomy and you don't have a tumor, it probably doesn't apply.
No, that's not true.
Prostatectomy, yeah.
Yeah, I mean, because the blood supply is critical for the tumor growth, no matter where it is. It doesn't matter if you have a prostate or not. You could have a small metastatic lesion somewhere, and it still needs a blood supply. So, that type of therapy could be appropriate. Just because you still have your or let me put it this way: if you don't have a prostate, it doesn't mean that the drug is not going to be of any use.
That's a good point. Very good point. If near the end it's attacking, let's say, your lung, then maybe it could give you quite a bit more survival.
No, it doesn't matter where it's attacking.
Yeah, that's what I'm saying.
It has, as Len says, and I agree with him 1,000%. Doesn't matter whether you've got a prostate or you don't have a prostate. The idea of the angiogenic treatment is that it stops the blood vessels multiplying to feed the cancer. And It doesn't matter where that cancer is. It could be in your lymph nodes.
Right.
So the question is, does that treatment have a role in prostate cancer? And the answer is that there are certain drugs that are used that are partly angiogenic. And we should explain. Len, do you just want to explain the term angiogenic? Because some people may be saying, what the hell are they talking about?
Oh, Len, we can't hear you.
Sorry about that. There was a dog, the hound from hell, I call it, outside barking like crazy. Maybe you still hear it. But anyway, Angiogenesis is a term used to describe the growth of new blood vessels. Tumors grow very rapidly, and oftentimes they're growing in hypoxic or low oxygen environments, and so they need to be fed with new blood vessels to bring in the oxygen and nutrients for the rapid growth. So an anti-angiogenic drug will prevent the formation of those blood vessels, new blood vessels. It's believe it or not, everybody is old enough here probably to remember the drug thalidomide.
Yeah.
That's an anti-angiogenesis drug, and of course it was disastrous for pregnant women. I think it was in their first trimester if they were using it, because it prevented blood growth in the fetus, and they had all kinds of deformities. That, of course, that type of thing is not of concern for someone with prostate cancer or any adult with cancer. So yeah, that's about it.
Yeah, and there are certain doctors who are not necessarily amongst our favorite, who prescribe thalidomide still today to men with prostate cancer, believing that it has some benefit.
I know a couple of people that were on Avastin for different cancers that were no longer here, but it seems like the doctor went to that late in the game for both of them. They didn't put them on early. They used other things, and then like, let's try Avastin, see what that does.
What was it called, Peter?
Avastin?
No, Avastin.
Oh, you're talking about something different.
Yeah, Avastin. A-V-A-S-T-I-N.
Okay. Now, you know, there's a lot of, I just put one abstract in there. There's a lot on the internet about anti-angiogenic therapy for prostate cancer. And, you know, there's still research that's going on. So I don't want to say that it's gone. It's always strikes me as it's one of those drugs, one of those processes that can be helpful maybe in the context of other processes. So you take this drug in combination with another drug. I don't know enough about it, but I do know that it's not a dead subject, Paul, but it's neither is it a magic bullet.
Right. So do we know anybody that's tried it or that has been prescribed it?
Yeah. I mean, I've known, but Peter just mentioned two people, and I've known people over the years that have been on anti-angiogenic drugs, usually quite late, and it hasn't helped them that much.
Okay.
But it's not something that I would. I'd be much more concerned in studying this drug that we mentioned at the beginning, 110. What are the letters? What are the letters for it? ARV 110, and Protac, which to me sounds a lot more exciting in terms of a prospective magic bullet than anti-angiogenic drugs.
What were those two? ARV-10, did you say?
ARV-110. If you listen to the call, I know you came on a little late, but if you listen to the call, we talk about it quite a bit at the beginning of the call.
And what was the other one? ARV-110, and the other, you said something else?
No, that's this new trial that's just been fast-tracked by the FDA.
I see. Okay.
Okay. And we'll be writing more about it as we learn more about it. Okay, gents. We're only 8 minutes over. I think everybody got to talk about everything. Is there anything anybody wants to raise before we finish up?
Yeah, I just want to mention that came out of my meeting yesterday that was pretty neat and surprising. I'm going to do some research on it, and I'll let you know about it. This guy down in San Diego was shopping around for a second opinion on his pathology, and he happened upon a pathologist down there who invited him into her lab and had a double microscope set up and kind of went through the whole process with him, looking at his, describing to him how she counted, how she looked at his pathology, and how it worked. And I thought that was pretty cool. She trained under Epstein. I'm going to do some research on her and see if there's another go-to person, but sounds cool.
Yep. And she was good looking to boot, he said.
Okay.
Is that the lady you were talking about last night, Hansel?
Yes. Yeah.
Okay.
Look her up.
Yeah, and since Peter now has a testosterone level of 100 to San Diego. before his girlfriend comes back from Minneapolis.
Hey, careful, Rick. Susan might listen to these recordings.
Oh, that's right. Yeah, she might. She may well. Listen, we're allowed to tease on here. We're allowed to tease.
You can always look, Peter. Look, but don't touch.
Yeah, thank you for mentioning that. We didn't. Speaking of which, we didn't get Jim Kubat on this call, did we? To talk about when he should intervene and do what he's got to do.
I'll report more next month on that one.
Okay. All right. Okay, gents. So thank you all.
Thank you.
Thank you.
17th.
Thank you.
Night, everybody.
Okay. Talk to you next week. Goodbye, everybody.
Yeah.
Night.
Bye.